Assalamu alaikum. This is Dr. Mariam Al-Abdallah. I'm a professor in orthodontics at the University of Jordan, and I'm a senior orthodontic consultant at the Jordan University Hospital. And this is going to be our second lecture on craniofacial growth and development. Just to confirm that our reference is Chapter 2 from Prophet, Contemporary in Orthodontics. And last lecture we covered the first 5 topics, and this lecture we're going to cover the last 2, and we're going to apply all the concepts and terminologies that we learned in the first lecture on these sites of the craniofacial complex. We're going to start with the cranial vault. As you know, the cranial vault consists of different pieces of bones: the frontal bone, parietal bone, and the squamous part of the temporal bone and the occipital bone. The cranial vault, first sign of ossification actually appears at week number 8 intrauterine, and the type of bone formation is intramembranous ossification. So what happens is that the brain is covered with a membrane called ectomeninx. The upper part of the ectomeninx will act differently than the lower part. The upper part will act as a soft tissue that will get condensation of cells, and it will get invaded by blood, and then we will start to have osteoblast, extracellular secretions will start, and then ossification will appear. Different islands of bone will get bigger, and they will come closer until we get very small areas of soft tissues remaining. We call them fontanelles. At birth, we get 6 areas of fontanelles: the anterior, the posterior, 2 at this side, the mastoid and the sphenoid, and 2 on the other side. At age 18 months, 1.5 years, those fontanelles will disappear, and they will be replaced by fibrous sutures. And later on, those sites, suture sites, will be the sites of growth later on. So if we go back to Scammons's curves that is explaining about the pattern of growth of different tissues, we will find that the cranial vault will actually follow closely the neural type of pattern of growth, because it responds to the growth of the brain. And so we expect it to grow immediately after birth all the way till about 7 years of age, and then it will cease growth or slow down because it responds to the brain. Now what happens, as we said, the brain will increase in size. This brain will push the covering bones apart, and that will produce tension in these sutural areas, and that will enhance bone formation. The bone will be pushed apart and pushed outward, and this is what we call primary displacement or translation of the cranial vault. At the same time, we will experience surface remodeling, and that is bone resorption from the inside, new bone formation at the outside, so that the calvarium will accommodate the new shape and size of the brain. All sutures will fuse around 7 years, as we said, because the pattern of growth of the calvarium, the cranial vault, follows closely the pattern of growth of the neural tissues according to Scammons's curves. Now, the second site of growth is the cranial base. The cranial base consists of the ethmoid bone, the sphenoid bone, and the occipital bone. Now, what happens in the cranial base is different from the cranial vault, because the ectomeninx that covers the lower border of the brain actually acts differently. It will differentiate to chondrocytes, and then chondrocytes will start to form cartilage. This cartilage is a primary cartilage. So we will have cartilage first, and then this cartilage will get invaded by blood, and then we will have bone formation. So the type of bone formation is endochondral ossification. And this is why the first sites of ossification will actually start at month number 4 intrauterine. And why is it later than the cranial vault? Well, because simply we need to form cartilage first, because this is endochondral ossification, and after that this will be transferred to bone. So these shaded areas represent the islands of bone that start to form within the cartilage. Eventually they will increase in size and the amount of cartilage will reduce, and we will end up with bigger pieces of bone and smaller bands of cartilage in between. This band of cartilage is called synchondrosis. So we will have sphenoethmoidal synchondrosis. Here we will have the intersphenoidal synchondrosis, and here the spheno-occipital synchondrosis. And again, if we go back to Scammonn's curve, we will find that cranial base is going to be between the neural pattern of growth and the general pattern of growth in between. The anterior part of the cranial base will follow closely the neural part, while the posterior part will follow the general part according to the structures that affect their growth. So the anterior part will be affected by the brain, and the posterior part will be affected with the rest of these structures. The growth in the synchondrosis is very important to maintain the increase in length and the proper shape to accommodate the sinuses, etc., etc. And the type of bone formation at those synchondroses, as we said, is endochondral ossification, and the type of cartilage is primary cartilage, which means it's a growth center. In addition to growth at the synchondroses, we will have bone remodeling in order to accommodate the shape of the change in shape and size of the brain and associated structures and the formation of sinuses like the sphenoid sinus, etc. So this is the sphenoethmoidal synchondrosis and the intersphenoidal synchondrosis and the spheno-occipital. The intersphenoidal synchondrosis will actually fuse before birth, while the sphenoethmoidal synchondrosis will fuse at around 6 years of age, because this part here, the anterior part, follows the neural pattern of growth. So if the brain will stop about 6 to 7, then this should fuse around 6 to 7 years of age. But the third synchondrosis, the spheno-occipital synchondrosis, will maintain growing actively up to the age of 15 for females, up to the age of 17 for males. So males, it's even 2 years later. And this will affect greatly jaw relationship, the relationship between the maxilla and the mandible. Because as growth here occurs, this will affect the length of the cranial base, and it will affect the angle, the orientation of bones. And since the occipital bone, sphenoidal bone, and ethmoidal bone are related to the temporal bone, and the temporal bone carries the temporomandibular joint area, and this is attached to the mandible, then eventually any changes in the length of the cranial base and the angulation and orientation of those bones together will affect the orientation and the position of the mandible. So this is an angle that is really important. It is called the saddle angle. So if we look here, this is the saddle angle. If this angle is acute, small, that means the mandible is pushed forward, and that means that the patient is most probably is going toward class 3 skeletal pattern. If the length of the cranial base is small, this means that the mandible is going further forward, again class 3. If the angle is obtuse, big, that means the mandible is pushed backward, that means it is more toward class 2. If the length of the cranial base is big, long, then that means the mandible is pushed back again, and then we will have class 3 tendency. So as we said, the angle is important to determine the jaw relationship. So the first one here is showing you a relatively short length, and the angle is a little bit acute. So the patient is more toward class 3 skeletal pattern. The length of the cranial base posteriorly here is longer, the angle is more obtuse, and we will have a tendency of a class 2 relationship. It's more here toward the average, just in between, and the patient is having a class 1 jaw relationship. Right now we will come to the maxilla. The maxilla is formed by the intramembranous ossification, and the first signs of bone formation actually occurs between the 6th to the 7th week intrauterine, and it is considered the third bone to ossify following the clavicle and the mandible. So the clavicle is the first bone, the mandible is the second, and then the third one is the maxilla. And the initial condensation of mesenchymal cells will actually occur lateral to the nasal capsule. So the nasal capsule will be merely the structure to guide the condensation lateral to it, but it will not contribute to the formation of the maxilla. Now, this condensation of mesenchymal cells will be invaded by blood, etc., until we get the intramembranous ossifications. And after birth, what happens is that this maxilla will further grow and develop by primary displacement. Primary displacement is the result of the growth of the surrounding structures. The envelope where the maxilla is embedded will grow downward and forward, and this will push the sutures apart, and it will enhance formation of bone at those sutures, as if the maxilla is moving downward and forward through primary displacement, which is an active growth. At the same time, we will have bone remodeling, where we will get bone resorption at the anterior surface of the maxilla and a new bone formation at the posterior surface of the maxilla, as if the maxilla is going backward. And finally, we will have secondary displacement. As the maxilla is attached to the rest of the skull, then as the skull and the cranial base and bone will grow downward and forward, it will carry the maxilla with it passively. And this is the secondary displacement. Now, to sum up, the maxilla will move downward and forward as a result of the primary displacement with the associated soft tissues. And it will move in the same direction downward and forward as a result of the secondary displacement. And at the same time, it will move backward as a result of bone remodeling. So this guy here represents the displacement, the primary and the secondary, moving the maxilla forward and a little bit downward. Those guys are representing bone remodeling, where we have anterior resorption of bone and posterior new bone formation. Now, the primary displacement will continue on up to 15 years for females, 17 for males, but the secondary displacement will actually stop before that because it is related to neural growth. So about 6 years of age, 7 years of age, this secondary displacement should stop. As the palate is part of the maxilla, then we will have remodeling of the palate as a result of function and need to increase the volume of the nasal cavity. So we will have resorption of bone at the floor of the nasal cavity, and that is the top of the palate, and bone formation at the top of the oral cavity, and that is the bottom of the palate, as if the palate is moving downward. And because the palate, as we said, is part of the maxilla, and the maxilla is moving downward and forward, then we will have the secondary displacement in the same direction. Not to forget the transverse development of the maxilla that will carry the palate with it. So the both parts of the palate, the left and the right, will be pushed apart. And then at the median palatal suture, we will have active formation of bone to accommodate the transverse growth and expansion. So as we said, the growth of the maxilla will continue up to 15 years in females and 17 years in males. Now the last part is the mandible. And first signs of ossification for the mandible actually start 6 weeks intrauterine, and it is the first bone in the craniofacial structures and the second bone after the clavicle within the whole body. And again, Meckel's cartilage will only guide condensation of mesenchymal cells at its lateral surface. And then this condensation of cells will start to get initial sites of bone formation, and bone will form following the type of the intramembranous ossification. So the cartilage only important to guide the condensation of cells. It doesn't contribute directly to the formation of the mandible. But Meckel's cartilage will eventually contribute to the formation of some of the small bones within the middle ear, but not contributing to the formation of the mandible. Okay, so these are the initial sites of bone formation, and that will be the start of the formation of the body, and a little bit of the angle of the mandible, maybe a little bit of the ramus, but the condyle will start to form much later at about 10th week intrauterine, and it will start to have condensation of cells that will form cartilage, and this type of cartilage is a secondary cartilage. That means it's a growth site, not a growth center. And it will form independent of the rest of the body of the mandible. And then early in fetal life, it will fuse later on as it grows with the mandibular ramus. The type of bone formation of the body, as we said, is the intramembranous ossification, but bone formation at the condyle is endochondral ossification. So this is different from the maxilla. The maxilla is purely intramembranous ossification, but the mandible, there are two ossification processes that contribute to its development: the intramembranous ossification of the body and part of the ramus, and then the endochondral ossification of the head of the condyle, and that will contribute to the increase of the length of the ramus and the development of the mandible. Now, the cartilage that will cover the condyle will stay active for a certain time, and then it will cease in growth later on. Now, what happens after birth? Again, the soft tissue that surrounds the mandible will grow and develop, and it will push the mandible forward and downward, just like the maxilla. But the mandible doesn't have sutures like the maxilla. Instead, it has temporomandibular joint. So as the mandible is pushed forward and downward, we will have active formation of bone as a reaction at the head of the condyle. And this is what we call primary displacement, because the mandible itself is doing the active bone formation and growth. At the same time, we will have bone remodeling to accommodate the development of the teeth and the molars and the associated structures. So we will have active bone removal, resorption at the anterior surface of the ramus, and active bone formation at the posterior surface of the ramus, as if the ramus is moving backward. Now, we know that the mandible is attached to the rest of the skull through the temporomandibular joint. And as the cranial base and the saddle angle modify and increase in length, etc., it will affect the position of the mandible. And this is what we call secondary displacement, because the mandible will be affected passively as it is attached to the rest of the bones of the skulls. So overall, we will have primary displacement, secondary displacement, and bone remodeling of the mandible, and this will contribute to the final shape and position of the mandible. Now, before puberty, we will get 1 to 2 millimeter increase in the ramus height per year, while the body length will increase by 2 to 3 millimeters per year. During the adolescence growth spurt, this should double. And this is why it's important, if we're planning for growth modification, orthopedic effect, then we need to aim to start the treatment during the puberty and growth spurt to get the best results. Adult level The adult size level of the mandible will be reached at 17 years of growth, so this is 2 years later than the maxilla, and 19 years in boys, and that is again 2 years later than the mandible, the maxilla as well. And the reason why, because of the cephalocaudal gradient of growth that we talked about last lecture, the mandible will grow later and further according to this concept. So not to forget the transverse dimension, we will have transverse expansion, transverse increase in the dimension, and this should be followed by bone remodeling to accommodate the new position, the new structures and shape of bone. So if we go back to Scammond's curve and we look at the maxilla and the mandible, we will find that the maxilla will follow a curve that is in between the neural and the general growth pattern, but it is more close to the neural, while the mandible is more close to the general. And it does make sense because the maxilla is closer to the cranial base that is affected by the growth of the brain, while the mandible is further away from that effect. Rotation of jaw during growth. So it's not a simple one dimension. It's not like forward, downward growth rotation direction. There's also rotation that is happening for the maxilla, because we know that the primary and the secondary displacement of the maxilla is opposite to the bone remodeling. Then growth rotation is almost completely masked by surface remodeling, so as if the maxilla is not changing in position with all these things going on. For the mandible, on the other hand, we will see actually growth rotation that is significant. Now, 80% of the population will have a type of rotation that we call forward or anterior growth rotation, and usually it is an anti-clockwise rotation. So this is the anterior growth rotation. And only 20% will get the posterior growth rotation, that is a clockwise or backward or posterior growth rotation. Now, if we look at the factors that determine the posterior and the anterior growth heights and rotations, we will find that the posterior facial height is determined by the direction of growth of the condyles, the spheno-occipital synchondroses, and the masticatory musculature at the ramus. The anterior facial height, on the other hand, is affected by the eruption of teeth, vertical growth of soft tissues, and it is influenced by growth of the spinal column. So why is this important to talk about the posterior and the anterior facial height? Well, because when we talk about jaw rotation, by definition, it is the ratio. The rotation is represented by the ratio between the anterior facial height and the posterior facial height. So if the anterior facial height is increased, plus minus, posterior facial height is reduced, we will have posterior growth rotation. While the opposite is the opposite. So if we have reduced anterior growth height, plus minus increased posterior growth height, then we will have anterior growth rotation. Patients with marked rotation, so if a patient has anterior growth rotation and it is significant, not within the average, not the normal, then usually these patients with anterior growth rotation, the patient will experience reduced anterior lower facial height and increased overbite. Patients, on the other hand, with significant posterior growth rotation usually will have an increased anterior lower facial height, reduced overbite, or sometimes even anterior open bite. So what's the normal? So this is a radiograph showing you the patient with anterior growth rotation, reduced vertical proportions, and a patient with a huge posterior growth rotation with anterior open bite, increased lower facial height. So the average is to have mild anterior growth rotation, not significant, mild. This is the average. This is the 80% of the population. Now, how can we explain the growth in the craniofacial structures? We talked about the growth itself, but how is this controlled? Well, there are three theories to explain this: suture theory, cartilage theory, and functional matrix theory. The suture theory claims that the bone is the primary determinant of growth. So within the bone, we have all the control factors we need, genetic factors, all the elements that is necessary to control growth. Now, this theory was not supported by the experimental evidence. So if we isolate sutures in a lab environment, it will not continue to grow. But if you apply pressure and external forces to those sutures, they will respond, but they will not react. So it's not like acting independently. They are dependent, and the control of growth does not exist in bone. So this theory was weak. Now, the cartilage theory claims that the growth factors and growth control actually is found within the cartilage. And if we look at the primary cartilage and secondary cartilage, we will find that actually this is partly true. For the primary cartilage, it is considered growth center, where the growth control is there. The example is the synchondroses of the cranial base and the nasal septum. So if you isolate this in an environmental lab environment, then it will grow independently. On the other hand, secondary cartilage, like the mandible, the condyle of the mandible, if you isolate it, it will not grow independently, so it is only growth site. So this is not a complete explanation of the growth control. The third theory is the functional matrix theory, and here this theory states that the control factors for growth actually exist within soft tissues. So the soft tissue matrix or envelope where the bone is embedded will carry the control factors for the growth. So the function, the development of those soft tissues should initiate, direct, and control the amount and direction of growth of the embedded bone. And this is, if you remember, we call this the primary displacement of the maxilla and the primary displacement of the mandible, where soft tissues are actually pulling them downward and forward. This theory was suggested by Moss in the 1960s, and it was very much accepted that in the 1997, Moss published a series of articles, 3 to 4 articles, that explained further this theory in depth, taking into consideration all the elements and the mechanisms and everything related to it. So if the function surrounding the bone is normal, so normal swallowing, normal breathing, speech, feeding of the baby, all these functions is normal, growth of the soft tissue is normal, then this should initiate, control, and guide normal growth of the bone. If we have problems with the function, this should carry and affect growth of the bone. So this is finishing the topic of the craniofacial growth and development, and this is my email for you to contact me for any further details.